Hi to everyone. I am Dr. Rana Pratap MAURYA from Department of Orthodontics, School of Dental Sciences, Babu Banarsi Das University, Lucknow. Today's lecture topic is Preventive Orthodontics. So there are various branches in orthodontics. One is Preventive Orthodontics, Interceptive Orthodontics, and Corrective Orthodontics. Prevention means the effort which are made to maintain normal development, physiological function, and to prevent disease of mouth and adjacent parts. We know that prevention is better than cure. So preventive orthodontics is a continuous process. Unlike others, certain phases of dentistry which are one shot process. Means in other branch of dentistry, the treatment can be done in very few appointments. But orthodontics is continuation process. It takes years. Also, in many procedures are common in preventive as well as in interceptive orthodontics. But the timing of application of the treatment procedure varies, like space maintenance and space regaining. Space maintenance means we give a space maintainer before the loss of space just after the premature exfoliation of deciduous teeth. Whereas space regaining means when there is space loss and we are going to regain the lost space. And second example is removal of mesoderms before midline diastema closure is means when we extract the mesoderms before appearance of midline diastema, that is preventive orthodontics. When mesoderms removed after the diastema appearance, that is interceptive and or corrective orthodontics. So various definitions are given according to Graeber. The action taken to preserve the integrity of what happens, what appears to be normal at that specific time. And according to Profit and Ackerman, the prevention of potential interference with occlusal development. So preventive orthodontics is that branch of orthodontics which is concerned with the patients and parent education, supervision of growth and development of dentofacial structures, and the early recognition of deviation from normal. It involves the various diagnostic and treatment procedure which are instituted to prevent the onset of malocclusion. The aim and objectives of preventive orthodontics: first, to anticipate or detect the abnormal function and development, to take steps to preserve abnormality whenever possible, and to institute measures to correct abnormal pattern where it has already set in. And permanent dentition with all teeth in good alignment and contact anatomically compatible with a healthy periodontium. Dental arches were related in all three planes of space with an optimum intercuspation. Dentition in harmony with aesthetics in frontal and profile appearance. Stability between skeletal, dental and muscular components. The procedures which are undertaken in preventive orthodontics are: first, without appliance therapy. Here we did not use any appliance in these procedures, like parent education with prenatal counseling, pre-dental care, oral hygiene and care of deciduous dentition, caries control and restoration of decayed tooth, monitoring of transition of primary to permanent dentition, occlusal equilibration, extraction of supernumerary and over-retained deciduous teeth, management of ankylosed tooth. Management of deeply locked first permanent molar due to mucosal or bone barrier. Management of abnormal frenal attachment like tongue tie and disking of primary tooth. And procedures which are instituted with appliance therapy or elimination of abnormal oral habits, space maintenance, mouth guard and protectors during contact sports. First, parent education. Ideally, it should be start much before the child's birth. In this, counseling may be divided into two stages. One is prenatal counseling, means before birth of child. Postnatal counseling, which are 6 months to 1 year, 2 years of age, at 3 years of age, and at 5 to 6 years of age. So in prenatal counseling, the importance of oral hygiene maintenance by mother is educated to the parents. So there is a possible correlation between poor oral hygiene and premature birth, because in poor oral hygiene, there is chances of inflammation of gum tissue, which release prostaglandin, which causes premature birth. And also the expecting mother should be educated about the type of nutrition, means they should provide a good nutrition. Second is genetic counseling. Certain malocclusion are genetic in origins, like cleft lip and palate, class 3 malocclusion. So the patient should be educated or should be informed before the child's birth. In postnatal counseling, which starts 6 months to 1 year of age, where we know that the first tooth, deciduous tooth, which erupt is at around 6 months of age. So in this time period, the instruction given to parents are regarding pre-dental care of child before eruption of any tooth. Means there may be teething problems before eruption of teeth, and also the importance of mother milk over the bottle fed milk. Means mother milk is superior as compared to the bottle fed milk. If bottle fed milk is provided, then the use of physiological nipple is good and not the conventional nipple. And we should advise against the prolonged use of pacifiers and sweetening solution in bottle, because they cause rampant carriage, or also called a nursing bottle syndrome. So in conventional nipple, which is also called a non-physiological nursing, with a conventional artificial rubber nipple, the mouth is propped open unduly, and the lip seal is difficult in this type of nipple. And also the air intake with milk intake is likely occurs, and the abnormal muscle pressures are exerted as a compensatory response to the excessive mouth opening required. But in case of physiological nipple, the nursing action of neck sauger, means physiological nipple, they closely stimulate natural activity. The perioral area is able to contact the warm nipple base here, which is flexible and adapts to the contour of lips. So there is less chances of intake of air. And pacifiers and bottle feeding, it should be avoided, because in nursing bottle carriage, which happens when the sweetened drinks like milk, formula, fruit juice, or pacifiers which are dipped in the sugar are given, particularly at nap time or at night. So these pacifiers and meals, sugar in meals, they cause carriage, which is called a nursing bottle carriage or rampant carriage. This is initial stage of rampant caries or nursing bottle caries. This is advanced stage of nursing bottle caries. So also the parents should be educated about the teething problems, and also the brushing with the help of finger during bathing, and cleaning up deciduous dentition with a clean, soft cotton dipped in a warm slime. Nowadays, a silicone brush is also available, which we can put in fingers, and brushing or cleaning up the deciduous tooth should be done. At 2 years of age, the bottle feeding to be withdrawn completely by 18 to 20 months of age, and brushing to be initiated post breakfast and post dinner, and clinical examination to assess any rampant caries or decay and eruption status of teeth. This picture shows the incipient decays or caries. At 3 years of age, the dentition should be assessed for molar and canine relationship, any discrepancy away from normal, which may include unilateral crossbite hair, supernumerary teeth, or mesodense, missing teeth, or fused teeth. And also the oral habit and their effects on the development of occlusion should be considered and informed to the parents accordingly. Like thumb sucking habits, which may lead to class 2 malocclusion, apocrine upper anteriors and open bite. Mouth breathing habits, it may also lead to open bite, long face syndrome. This is lip trap and nail biting. They may lead to various malocclusion. It should be informed to the parents. And child should be also encouraged to begin brushing on his own at least once a day. At 5 to 6 years of age, parents to be informed about the initiation of exfoliation of deciduous teeth, and that is it goes up to 12 to 13 years of age, because at the 6 years of age, generally first permanent molar erupts and exfoliation of upper and lower, generally lower anterior starts. And at this time, need of constant review and recall on a regular basis is required. So in case of extraction of deciduous teeth due to decays, then need, advantage and importance of space maintenance should be advised for the parents. Next, caries control. Caries of deciduous teeth is principal cause of malocclusion of permanent dentition. So proximal caries, they causes loss of arch length by movement of adjacent tooth. To detect the caries, the proximal caries, wide wing radiograph are valuable tools. And also for caries control, nutritional and diet counseling is important, and fluoride applications, water fluoridation, pit and tissue sealant, they play a role in caries prevention. Care of deciduous dentition. So we know that a well restored primary tooth is best natural space maintainer. So the carious tooth has to be timely and properly restored to maintain the integrity of ours. And also the all efforts should be taken to prevent extraction of pulpily involved deciduous teeth. We should restore these tooth either by pulpectomy, pulpotomy, and also if required, we restore the tooth, we can give a crown to the tooth to restore the primary tooth. Next, extraction of supernumerary teeth. The supernumerary teeth can interfere with eruption of nearby normal teeth. Here this supernumerary teeth, it affect the extraction of central incisors. The central incisors which are erupting buccally due to presence of mesoderm. They can deflect adjacent teeth to erupt in abnormal position and cause malocclusion. So presence of mesodens prevent two central incisors from approximating each other. Here this is central incisors. So the mesodens, here mesodens, it prevents approximation of two central incisors. So supernumerary teeth, it should be extracted as soon as possible before the appearance of malocclusion. So extraction of overwritten deciduous teeth. The overwritten deciduous teeth can deflect adjacent teeth to erupt in abnormal position and cause malocclusion. Here the upper both central incisors are retained. So it causes lingual eruption of upper maxillary central incisors. So it should be extracted. Management of ankylosed teeth. Ankylosis is a condition characterized by absence of periodontal ligament in a small or whole of the root surface. So they cause either prevention of eruption of permanent teeth or cause deflection in abnormal position. Here we can see that this ankylosed tooth, they cause deflection of eruption of second premolars. So it should be removed surgically at appropriate time. And ankylosis deciduous teeth, they do not get resolved or resolve very slowly. Next is smooth transition of dentition. So maintenance of tooth shedding timetable and close monitoring of eruption timing and sequence. So permanent teeth should be erupt within 3 to 6 months after the exfoliation of deciduous teeth. So there should be not more than 3-month difference in shedding of deciduous teeth and eruption of permanent teeth in one quadrant as compared to the another quadrant. So delay in eruption may be due to presence of over-retained deciduous teeth or roots, premature extraction or exfoliation of adjacent teeth, and loss of space by drifting of teeth. Supernumerary teeth, cysts and tumors of jaws, overhanging restoration in deciduous teeth, overlying fibrous soft tissue, ankylosed primary teeth. So eliminating occlusal interference, all functional prematurity detected before they create malocclusions. It can lead to deviation in mandibular path of closure, which may develop to pseudo class 3 malocclusion and anterior crossbite. If it does not treat it timely, then it may lead to true class 3 malocclusion. And lateral shift may predispose to development of various parafunctional habits like bruxism. So premature contacts are eliminated by selective grinding. Then management of abnormal frenal arthritis. So presence of thick and fleshy abnormal maxillary labial frenum that is attached relatively low. We can see in this picture may cause development of midline diastema. So diastema can be diagnosed by Blanch test in which the upper lip are retracted upward and in labial directions. So it causes blanching of the tissue near the incisive papilla. So it should be all the mid high frenal attachment can be also diagnosed of the interdental notching of bone in the IOP radiographs here. So ankyloglossia or tongue tie may result in abnormalities in speech and swallowing. So surgical correction of high frenum and tongue is advised. Oral habits checkup and educating patients and parents. Abnormal oral musculature habits should be identified and stopped early before they transform into compulsive habits. It begins with proper nursing care and use of physiological nipple that stimulate normal suckling and swallowing pattern. So in oral habits such as thumb sucking, digit sucking, lip sucking, the child can be distracted from indulging in the same. In mouth breathing, the child can be given adequate medical attention regarding recurrent upper respiratory tract infections. So these are the thumb sucking habit It may lead to open bite conditions. Tongue thrusting habits also lead to open bite condition. Mouth breathing habits may lead to long face syndrome. So next, deeply locked permanent first molar. So deciduous second molars, they occasionally have a prominent distal bulge, which prevent the eruption of permanent first molar. Here we can see. So proximal reconstruction of distal surface of second deciduous molar, it helps in eruption of first permanent molar. We can see in this diagram. Next is space loss and space maintenance. This is also important part of the preventive orthodontics. Space loss is one of the major contributors to malocclusion in the permanent dentition, along with ectopic erection or impaction of the teeth. So incidence of space closure is related to length of time since extraction. Longer the time of extraction, the greater the incidence of space loss. The maxillary space have higher rate of closure than the do mandibular space, because in maxillary arch the bones are cancellous and in mandibular arch they are more compact. So maxillary second deciduous molar have a substantially greater average rate of closure than the other premature extraction space. So space maintenance, it is an important phase of preventive orthodontics. Space maintenance may be necessary after premature tooth loss in primary and mixed dentition to preserve the arch length, arch width and arch perimeter. So space maintenance can often prevent space loss and either prevent the development of a later malocclusion or reduce its severity. So careful consideration of many factors is required when deciding whether space maintenance is indicated. So consequences of premature loss of teeth, which include loss of arch length resulting crowding of the permanent dentition. They also cause impaction of permanent teeth. Here we can see malocclusion and other problems, drifting of adjacent teeth into the extraction space. Here shift in the midline of dental arch. So the premature loss of deciduous anterior teeth, it may result in aesthetic problem. There is, if anterior tooth are lost, then there is a aesthetic problem, and also it causes speech problems and functional problems. But space loss is rarely observed due to loss of anterior tooth. So usually in this case, space maintenance are not required, especially except for the aesthetic purpose. Next, premature loss of deciduous canine. It occurs due to the arch length discrepancy with erupting permanent incisors. So following unilateral loss of primary canine, immediate extraction of contralateral side should be considered to prevent the midline discrepancy, and lingual holding arch in lower arch and lens holding arch in the upper arch should be given. Premature loss of deciduous first molar, it causes mesial movement of posterior teeth as well as lateral movement of anterior teeth takes place to close the space. Effects depend on the stage of occlusal development. Here, if premature exfoliation of D occurs before eruption of first permanent molar, then E is shifted in the place of D. Here, the posterior teeth, it shifts in mesial direction and anterior shifts in distal direction. It causes impaction of 5 or label eruption of the 5. If premature loss of deciduous second molars or loss prior to eruption of first permanent molar, the permanent molar, it erupts mesially. As a result, the permanent second molar is impacted here. and gets ectopically erupted like this. But if primary second molars are lost, this second molar are lost after the eruption of permanent first molar. Here, the primary second molars tilts distally and the permanent first molar tilts mesially, and it preventing eruption of premolars. Here, this premature loss of second deciduous molar, it causes mesial tilting of first permanent molar and distal tilting of this deciduous tooth, which causes impaction of premolars. If one of the first permanent molar loss, then it is lost before eruption of permanent second molars. Then it erupts into the place of first permanent molar. Space maintainers. It is defined as the appliances that prevent loss of arch length and which in turn guide the permanent teeth into correct position in the dental arch. We know that the best space maintainer is primary tooth. These are the various types of space maintainers. Factors to be considered for the space maintenance. First, time elapsed since the loss of tooth, dental age of the patient, amount of bone covering the developing succedaneous tooth buds, stage of root formation, sequence of teeth eruption, congenitally missing teeth, eruption of permanent tooth in the opposite arch, and oral muscularization and habits. So these factors should be considered before giving any space maintainers. So indication of space maintainers: when force acting upon tooth are unbalanced and the space independency for the succedaneous teeth, as when there is a malocclusion or abnormal oral habits. When a malocclusion exists, that would be further compounded with loss of space. Regardless of child's chronological age, it is advisable to place a space maintainer if the tooth is not ready for eruption and delayed or altered eruption of premature teeth. So contraindication of space maintainers: when there is no alveolar bone overlying the crown of erupting tooth and there is sufficient space for its eruption. When space left is in excess of the mesodistal dimension required for the eruption and space loss is not expected. When there is a gross space discrepancy requiring further extraction and orthodontic treatment. When permanent succeeding tooth is congenitally absent and space closure is desired. Ideal requirement of space maintainer: it should be maintain the desired mesodistal dimension of space. It should not interfere with physiological vertical eruption of the opposite teeth. It should not interfere with eruption of permanent teeth. It provides mesodistal space opening when it is required. It should be simple in construction with minimum inventory. So it should maintain individual functional movement of teeth as well as should not interfere with normal function of oral cavity. It should be strong enough to withstand the normal functional forces. It must not interfere with the normal growth and development of the dental arch and changes that take place during the transition from deciduous to permanent teeth. It must permit maintenance of oral hygiene. The types of space maintainer, the various classifications are given. It should be functional or non-functional, fixed or removable, with bands or without band, active or passive, and certain combination of above. So removal space maintainer, the functional and non-functional. In functional space maintainer, it incorporates teeth to aid in mastication, speech, and aesthetic like this. In non-functional space maintainer, they have only acrylic extension over the edentulous area to prevent space closure. The acrylic partial denture used in patient undergone multiple tooth extraction, like here. So it can be readily adjusted to allow the eruption of teeth by trimming of the acrylic. So complete denture used when all primary teeth are removed due to rampant caries. In this, the posterior border of denture, it should be placed over the area approximately the mesial surface of unerupted first permanent molar, and denture portions are cut away and adjusted according to eruption of the teeth. So indication of removal space maintainers. In case abutment teeth cannot support a fixed appliance. In cleft palate patients who require obturation of palatal defect, if permanent teeth have not fully erupted, it may be difficult to adopt bends, and multiple loss of deciduous teeth, which may require functional replacement in the form of either partial or complete dentures. Next, fixed space maintainers. First, band and loop or band and bar space maintainer. This is band and loop space maintainer. This is band and bar space maintainer. This is most common type of space maintainer. In this, the tooth distal to extraction space, it should be banded and loop of thick stainless steel wire is soldered to it with its mesial in touching the tooth mesial to the extraction space. Next, lingual arch space maintainer. This is lingual arch space maintainer. This is most effective appliance for the mandibular arch. It indicated to preserve the space created by multiple loss of primary molars. Yeah, multiple loss of primary molars. It helps in maintaining the arch perimeter by preventing both mesial drifting of molars as well as lingual collapse of anterior teeth. Next, transpalatal arch. It used to stabilize maxillary first permanent molars when primary molars required extraction. Best indication of transpalatal arch is when one side of arch is intact and several primary teeth on other side are missing. Next, palatal arch appliance, which is also called a Nance palatal arch. It is similar to the lingual arch, like here. It is used to prevent mesial migration of maxillary molars. Here, a click button is placed on anterior part of the palate. So it does not contact the anterior teeth but approximate the anterior palate. It has an acrylic button in anterior region contacting palatal tissue. Next, distal shoe space maintainer. It is also known as intra-alveolar appliance. So it guides the path of eruption of unerupted tooth and prevents undesirable mesial migration. Here this is distal space maintainer. The distal part here in the radiograph we can see that this part it guides the eruption of first permanent molar. These are especially used when the second primary molar is lost before eruption of first permanent molar. Next, aesthetic anti-space maintainer. This consists of a plastic tooth which is fixed on the lingual arch, which in turn is attached to the molar band. Here this is molar band. Here this acrylic tooth, these are attached to this Nance palatal arch and these are fitted to the patient's mouth. Thank you.